Goodwin Therapy Services.
Hi, everyone. I'm Rachel Williams. I am also with our home health team as the team's marketing manager, so it's nice to see you all.
Hi, I'm Connie. I'm the rehab director here at the GHA, so I met most of you here. So we're going to let the home health started for their service first, and I'll take it over in the middle for just our outpatient and inpatient services.
Thank you, Connie. All right, so let's get started here. All right, so we're starting with home health information right here. So who is Goodwin Home Health? Well, we are a home health agency that was acquired back in 2020. If you all are familiar with the community, the Virginian, the team was acquired from that community. So a lot of the team is still with us, which is great. A number of team members have been on the team for 5 years and been working together more than 5 years. So we serve residents not only in our buildings throughout Goodwin, Alexandria, Goodwin House Bailey's Crossroads, The View, but also outside of our buildings. And that's actually where we see the majority of our patients. We see a lot of folks in their homes outside of our buildings. So it's really exciting. We get to serve not only folks at our buildings, but also across our region. So we provide skilled nursing. We provide therapy. This includes physical therapy, occupational, as well as speech therapy. And so we do this in residents' apartments. So you do not have to come to the clinic. We come to you. And some examples of individuals who are appropriate to bring in these services, that's those who might have limited mobility. They're having issues getting to the clinic. They're unable to safely access the therapy gym. They require assistance to leave the apartment, or they are recovering from an illness or injury. Now, we are a Medicare certified home health agency. So once again, we provide nursing, we provide therapy, physical, occupational, speech therapy, as well as a social worker and a home health aide. And all of these services are covered by insurance. Now, the frequency of home health, it is typically a visit 1 to 2 times a week per discipline. So if you have a nurse come in, a nurse is probably going to be coming in about 1 to 2 times a week. If you have an order for therapy, physical therapy, once again, that'll be 1 to 2 times a week. Occupational therapy 1 to 2 times a week. So per discipline that's ordered, it's about 1 to 2 times a week, depending on what's going on. And the goal is to help individuals return to their prior level of functioning. So this is key to remember with home health. See it as that intermediate service between the skilled nursing facility or the hospital and the outpatient center. Now, who qualifies for these services? I gave a few examples just a couple slides ago about those who might be appropriate to utilize home health. Well, some examples here, maybe an individual is recovering from an illness, so pneumonia, COVID, or a new or worsening diagnosis. Maybe they've been discharged from the hospital or a skilled nursing facility back to their apartment. Maybe an individual has had a recent fall, or they're experiencing some new mobility challenges. Maybe they're unable to safely access the gym. And to utilize or to get services started, we do have to have that doctor's order, and a visit and a doctor's visit within the last 90 days is required. All right.
Okay, I'm going to go a little bit more into depth into our services. Starting with our skilled nursing, we are skilled services, so providing education on maybe a new or current diagnosis. So that could be hypertension, it could be diabetes, making sure that you understand, what the medicine's for, how frequently you're taking it, and, if it's new medicine, what are the side effects? Also, if you have a wound, let's say you had a fall and then now you have a wound and there needs to be frequent changing of the bandage that needs to occur every week, or maybe you had a hospitalization and you have some type of incision or wound after that that requires our skilled nurse to come to make sure it's healing, and they come back every week, make sure the bandage is changed. So that's another reason for skilled nursing. We also provide assistance with any feeding tubes, ostomies or drains, management of catheters, and also just to kind of clarify, the clinic assist with setup of, or the pharmacy setup of pill boxes. Our nurses, they're more on the education piece of the medication itself. So they will make sure if you really, want to learn to manage your medications independently and putting different things in place to make sure you could do that, that is definitely something that our nurse could assist with. But if it's something in terms of just needing the pill box filled every week, that's more dependent on, the pharmacy or the clinic to assist with those things. We do have a home health aide. And our home health aide is to assist with bathing only. So they come once or twice a week for bathing. So it's not to come in the morning and do a couple of hours of getting, assisting with the whole bath, the breakfast. And the difference is here is that these are the services that are covered by the insurance. So this is what the insurance is looking to approve. So we can do this in conjunction with home care. We've done that multiple times before. If some residents need, certain hours of home care, maybe it's only once every hour in the morning, but then they would like a shower through us later in the day, and we come once or twice throughout that week to help with a shower later on. And then we do have a social worker. Her name is Lauren Kipfer. She also is in conjunction with Care Connections, and she does come through, our services that we provide, and she with discussions on advanced directives. A goals of care discussion basically revolves around the current or chronic diagnosis and what that really looks, about. Do you, in terms of hospitalization or going to the SNF unit here. So, she really wants to make sure that she understands every rights and residents' wishes for those things. The skilled nursing, so Connie will talk a little bit more about that, but it's the unit down after you maybe have a hospitalization, the small house, yes. All right, so this is just here we go. To continue on about the therapy services, we have speech therapy, physical therapy, and occupational therapy. Our speech therapist can work on swallowing strategies, an assessment for language deficits, communication strategies. She does come to your apartment, really helps with breathing as well. In terms of physical therapy, after maybe a knee or hip and you go straight to your apartment potentially, or a fall, we're going to do an assessment of your balance and your gait to see your endurance and, really get a good idea of the balance score to see if there's a risk for falls. For occupational therapy, we're going to look at the apartment. This is really helpful in home health because we want to make sure that in your apartment you're safe. Do you have the grab bars that you need in your shower? Do you have the toilet rails? Is your toilet at the right height? Do you need a bedside commode by chance for a short period of time? What modifications in your apartment could we help with for a short period of time while you're recovering to increase your independence? In terms of the first visit, we just want to let you know a little bit more about what to expect. Because this is through insurance, there are a little bit more requirements on home health. For example, we do need to look at the medications. We want to see what you're taking. It's a very holistic approach. We go system by system to make sure, okay, are you breathing okay? Do you have any wounds? There's a skin check. We also are going to do an assessment about your balance or walking. We look at the insurance cards to make sure we're verifying that they are correct and we're billing the correct insurance. And we're also going to talk a little bit more about your plan of care and the frequency of visits. So it is a little bit lengthier. It's about an hour to an hour and a half of a visit, just through looking at the insurance cards, the meds, also the medical history, and finding out a little bit more about you. It takes a little bit more time. All right, I'm going to hand it off to Connie. Yes.
When you mentioned insurance coverage, what insurance are you talking about?
Yes, we cover our insurance is Medicare we bill, or we bill commercial insurances as well. So, and we do have a slide a bit further to discuss about our insurances, but we do take Medicare and commercial insurances. Yes.
In terms of the last slide you just said for the initial visit, it's about an hour and a half. Should the resident expect any, what I would call treatment during that time? Or is it pretty much an assessment, and then the second visit is when the treatment begins for physical therapy? Say it's a hip replacement, a fall, and, a hip fracture, and you're working with that. When should they expect the treatment?
Yeah, that's a great question. So the assessment does take a long time, but there should be some type of exercises provided during that initial visit as well to get you started and get you moving. So usually I give a little bit of homework during that visit, like, okay, let's get you started on 2 or 3 exercises that you could start doing in it, from the assessment. This would really help you. So
the small houses. I'm now discharged to my apartment, but I still need home health versus going downstairs. What do I do when I think I'm not having the same amount of treatment for that I was getting in the SNF?
So that's...
How does that tie to your regulations?
So usually our visits are anywhere from 45 minutes to an hour long per time period. Now we do take your vitals, so we are required to go through and make sure that, asking our questions about your medications, taking all your blood pressure, your temperature, your heart rate, and monitoring your respirations. So, and just asking generally how you've been doing. And then we go into our treatment of the exercises and balance exercises and providing an exercise program. So, it should be comparable in terms of time frame with outpatient wise, and Connie can speak a little bit more to that piece, but, and providing the exercises are just in a different spot in your apartment. So, and working, standing at the sink, maybe holding onto a chair, doing some balance exercises there, seated in a chair, but usually our entire sessions for treatment 45 minutes and an hour.
Another insurance question. Is long-term care insurance ever involved in this process? Do you accept it? Is that part of something you do?
That's a great question. Long-term care insurance, we normally don't coordinate with them. That's more of like home care, and they need that assessment piece through them. So it's more of working with the insurance, like Medicare or commercial insurances, through that piece. Mm-hmm.
But if Medicare covers this, is there any reason to have long-term care?
Some people have long-term care insurance as a supplement to be able to have more assistance with like the home care piece. So home care is private duty aides, and so they come for a longer period of time, and depending on the type of long-term care insurance you have, they can cover part of that private duty aid that would come for like getting you up in the morning to get dressed, giving breakfast. If you have to go downstairs or going out to an appointment, that would be more focused on the long-term care piece and coverage.
The therapy itself is covered.
Yes.
For how long? Is there a time limit?
When you admit to home health, you have a 60-day window, basically. And so usually patients stay on average, of 45 days of care.
Is 60 days a limit, or is that an average, or go beyond that?
It can go beyond that. It's just a period of time that they initially give you to start with. And then at the end of that time, if you need more home health, then we do another assessment to extend to another 60-day period of time.
Do you ever do any of this kind of work with the hospice people?
We work, our departments are separate, but we do, coordinate with them. For example, if we've had residents that maybe or patients in the community actually that are said, oh, maybe I'm not ready for hospice yet. I really want to try to get moving. I'm not super mobile, so I can't get down to outpatient, but I just want to see what I can do before, maybe going to hospice. They come to us, they try to get moving, they work with our skilled nursing and our therapist, and then, decide from that point. A lot of times our social workers are involved as well to help make that transition from one department to another department.
Thank you.
Mm-hmm.
Are you covering the at-home program as well as the two physical buildings and the view?
So we're going to be just covering the home health, the skilled portion piece, and then Connie is going to talk a little bit more about the outpatient rehab piece. And
Talking to your clients, where they are.
like
You serve the at-home group as well as those of us who live here?
yes.
Do you serve the view?
Yes, sorry. Yes, we go to all campuses. We probably have anywhere from 10 to 15 patients at each building, but the majority of our patients are throughout the community.
And they all have to be under Goodwin Limited, right? You don't do independent outside of Goodwin. I know that PT doesn't because of the way they bill, but.
So we admit patients, yes, all throughout the community. So, yes. So we cover Arlington, Alexandria, Fairfax, Loudoun, and Prince William County.
So if a patient was having difficulty getting billing cleared up with whoever the billing process involves, can you provide expertise for that?
Yes, if it's regarding home health services and getting a bill for those, we can address that within our home health department. Yes. No, as long as it's a service that we provided, we can definitely address that.
Let me give you an example.
Sure.
If a person has a spouse in hospice,
Uh-huh.
and that person has many avenues of expenses that are insurance covered, sometimes there's difficulty getting those things resolved.
I see.
Can your folks help them resolve those issues?
It would probably be best for them to go directly to the hospice department, just because I am not sure about their billing. We do have a billing department that assists with home health and hospice, but it would be best for them to address any billing questions specifically to the hospice department. Yeah. Does that answer your question?
Charmin might have a tip for us. If you're having trouble with all the streams of billing, you can talk to Monica Thomas, okay? And they also have staff here that do billing work, because it can be very confusing, because you actually have a whole set of different providers who are billing.
Right.
Now, this may be beyond your area of responsibility, but I know that hospice has a team of doulas who help Are those doulas capable? Do you know if they're capable of helping people with difficulties, with billing, and anything else that might be involved in that process of hospice?
I know that we do have the doulas through hospice, and I think that's a great question. And I'd be happy to find out more information for you about that through our hospice team. But I can get your information after, and I can connect you with someone who can give you that information.
That would be very helpful. I'm not asking for myself. I'm asking for people that I know are having real challenges in those areas.
Sure, I'd be happy to connect you with someone from our hospice team. Yes.
Maybe what this meeting is through the Health Service, Resident Council Health Service Committee. So maybe we can kind of summarize some of these key points where people need information.
Sure.
And a summary can be released. I'll check with Sarah Fine on that, with billing. And if we don't get all of the answers as to the point you need, get back with us and we'll eventually get there. This is very complicated, but so the questions are helpful. Some of the real meaningful answers we might have to provide to you in a follow-up memo.
Thank you.
That's great. Thank you, Gail. Yes, and we would love to get you, the answers you need about hospice, the doulas, and I know that we can find out more information, connect you about that. Yeah. Any other questions? Okay, I'll hand it off to Connie, and then we do have more slides.
Yeah, we will share it and we'll answer the question at the end. Am I loud enough, or do you need me use the micro? Okay. Let me see this one. Okay. So our slides will be, the first one will be off. So when we first starting try to do a presentation, we'll only talk about the home health and outpatient. Our rehab department here in GHA, we also service inpatient. So this part is more like inpatient, a small house. I know somebody has a question about where is the skilled service at. That would be in a small house. That's our health center. So our rehab department here at GHA will service both inpatient and outpatient. Inpatient means if you went to the hospital for whatever reason, you had a hip replacement, you broken hip, any reason you stayed in the hospital for more than 3 days, hospital stay, and you have a Medicare benefit, sometimes when you come back, you qualify for Medicare skilled service in the small house, not at your home. At your home will be the home health. In the small house and the health center there, you were receiving the nursing care, we call skilled nursing, physical therapy, occupational therapy, and the speech therapy. And it depends on what you need and why you go to the hospital for. So the lengths could be, up to, 21 days, or every stay in the small house, usually 21 days, 20-some days. Sometimes people stay longer. It depends what their need. They have more complicated cases in the hospital. So this is, I'm sorry, I'm going to correct the first one. This inpatient happens on James. So is anybody familiar with a small house? This happened in James. So on the second floor, we provide in-service, in-house rehab in inpatient. So this including all the physical therapy, occupational therapy, speech therapy, like as Tom helps talk about, the same service, which is in-house. We provide an inpatient. Basically, physical therapy working on a lot of balance, gait training, pain management. We have LSVT here. It's the Parkinson program. We do vestibular, rehab, and also joint replacement. Anything, we encounter from the hospital, we work on that. Occupational therapy is majorly working with a lot of self-care, and they focus on upper body, weakness or pain or anything you needed. And sometimes we do, if you're inpatient, we do a home assessment before you go home. If you are our independent living resident here, we do go to your home to assess it before we discharge you from the small house to make sure everything's okay before the home health take it over. That's a part of the service as well. And we also have a speech therapist in the building for inpatient, because sometimes when you come back from the hospital, sometimes not because you lost your memory or confused, because some people go through general anesthesia. There's a little confusion there. For a couple of days, you need somebody help you with orientation, help you with schedule day straight. Maybe some people may have a stroke or different things they need a speech language pathologist work on the communication. Our speech therapists here working on that too, also swallowing, because some people have an issue swallowing the pills, or sometimes you need a food to modify to a point because you can't eat the regular food, maybe they have to chop it. So those are part of the inpatient speech therapy service as well. So this is the skill part. We're talking about small house. I'm gonna go down to the outpatient side, which is most of you familiar here. It's the ground floor at G1. That's the big rehab gym down there next to the swimming pool. Everybody know where the rehab gym at, right? Okay, so that one is our specific outpatient setting. So we also, same thing, we provide physical therapy, occupational therapy, and then speech therapy. The criteria to have a therapy down there is two things. You need to have a physician's order. No better you get it from our clinic here, Dr. Croma Nelson's office, or you get it from outside your own doctor, which is fine, doesn't matter. Or if you have a specific specialist, some people go to the orthopedic doctor to get a physical therapy order, will take that, or occupational therapy order, or your primary doctor outside in community. As long as there's a physician's order, we can look at it and decide whether we can provide service or not. That goes for the physical therapy, occupational therapy, and the speech therapy. So normally we really want to have your order within 30 days. I know a lot of people come down here, they have an order 60 days ago or a year ago. That would be too long. Because the reason why is not we try to picky on the things, is within the 30-day or 60-day, there may be a change in your medical condition. We don't know about it. So you may have an order to working on foot, and you just had a broken feet. Broken foot. So we don't know. So we like to have the order within 30 days once you get from your doctor's office, to be cautious on things, okay? Also, in the outpatient, we do a little more than what home health can do. We do have a lot of modality down there, like e-stim, ultrasound. We have the heat, ice, and the diathermy equipment, so we can work on a lot of pain management. So normally if a home health have the patient specific need of pain management, including, okay, I have a shoulder pain, I have a hip pain, I have a knee pain, I have an ankle pain, or pain anywhere, usually come down to outpatient if you're mobile enough. Unless you can't get out of your apartment, then we really will refer to a home health first, let them work with you first till you're mobile enough, come down to outpatient. We do have some specialty program. Like I said, we have LSVT, which is a Parkinson program. We work a lot of Parkinson patients. It's an intensive program, so usually you have a participant 4 times a week. So that's an intensive program. We do have vestibular program. If you have any dizziness, or wake up in the morning, feel woozy, those kind of vestibular program, we can work on that. And our speech therapists specialize in the breathing program and the voice. If you come up you have a voice, volume's getting low, or you have a hard time breathing to catch your breath, that's a part of the program you can go. But we do have a lot of special program. You can always stop by rehab, ask about it. It's kind of too many here to go through them. The e-stim is electrical stimulation. So it's like electrical stimulation put on the pads on the part of you have a pain to help to relieve the pain. No, it's not needling. It's just a pad, electrical pad, like an electro light, yeah, electro pad, yeah. So here's a part to setting expectation for initial visit for outpatient rehab. The outpatient rehab, it happened in rehab gym, which is in G1. And we have PTOT speech assessment performed per the physician prescription, like we said before. And usually typical an hour long. We're probably not gonna go over an hour, maybe shorter, depends on your condition. If you don't have really complicated situation, probably take a shorter time. Most likely take an hour, the reason being, most people come to outpatient, live in independent living. So for the therapy to see you the first time, we have to take information, a lot of history. We need to get your medical record unless you bring your medical record in here, because we have to get it from your physician's office. Because normally you see those order doctors send over didn't really have much information. All they have is like see physical therapy for your back pain. That we don't have anything background. So take a little time to get history. If you've been here before, we might have your old record that take shorter time to take history. The session in the clinic, once the evaluation's done, usually most people come for therapy usually 2 to 3 times a week. It depends what your needs and how complicated your condition is. And it usually lasts about between 4 to 8 weeks. It all depends on if you, after 3 weeks of treatment, you feel like I'm doing great, no pain, I'm walking around fine, then that's the time when we talk about discharge. So it all depends, it's individual basis. We try to personalize the program for each one of the patients. So it's not like, okay, everybody come here for 4 weeks and see 3 times. No, we have to discuss about it. And in initial assessment, you can talk to a therapist about what your goal and what can we do. So that's the time we find out. That's a part. And some of the therapy in the outpatient are the same therapy you've seen in skilled nursing, which are the same group, my group. In a small house, you may see the same, therapy in the small house, and you're gonna see the same people down there in outpatient. Home health have a different group of therapists, not in my department, but they have their same therapies as well. I think there's a myth about people coming from the hospital. They try to decide, do they go straight to home health, or do they go to the skilled nursing side in the small house, or they go to outpatient? It depends on your case. For example, if you have a knee replacement, you would only do an outpatient, surgery. The doctor will discharge you the next day. Should you go straight to outpatient, or should you go skilled nursing, or should you go home health? All depends on what you can do on the first day. And how comfortable do you feel to stay home by yourself doing everything after the surgery? So most likely, I would strongly recommend anybody going out for selective surgery. You already know you have the schedule. Talk to the rehab department first. Stop by my office, talk to me. We can walk through it, see how comfortable do you feel, so we can notify our admission person in the small house. We feel like you might need to stay in a small house for a couple of days just for the help. We'll arrange that. We'll let the social work know, admission office know. If you would feel like, okay, you may not be so independent right after the surgery, you may need some home health in the apartment, but you don't need to go to the small house, we'll arrange that too. We'll let the home health know. And some good case is, okay, you come out of the hospital, you're totally mobile, not much pain, I can go home, then you come to outpatient. So, but it's on the different case basis. So we can't really cookie cut like everybody go to skilled nursing, everybody do home health, or everybody go outpatient. So we can have a discussion. If you know you're gonna have a surgery in the next couple of weeks or in a month, so we can talk about it first to decide it, okay? Any questions?
Along the point you just made, is another factor insurance coverage?
Yes.
Because if you go from the hospital to skilled nursing, you most likely will have insurance cover that. If you go from the hospital to your apartment, which is your home, and then go to skilled nursing, you may not have coverage through your insurance. It depends.
Okay, it depends. So for the skill service, we talk Medicare A. If everybody here have a Medicare A, there's skill service A. So they have a certain criteria to qualify you. So first you need to have a straight hospital stay. If you only stay there for 2 days, for 1 day, doesn't qualify you. Even you have a severe, something happened in hospital, you have pneumonia, different things, doesn't qualify you. And those 3 days, when I call hospital stay, doesn't including the ER visit. Because a lot of people, the hospital will keep you in the ER for 2 days. That don't come. They don't count at all. You have to be actually admitted hospital stay for 3-day hospitalization day. Then if you qualify for the small house, then the Medicare A will pay for 80% of the after 21 days, like they were paid, first they pay 100% in 21 days, and after that there's 80%, 20% you have to catch up. But if you have a secondary insurance, they will catch up till 30 days. So it depends on your insurance. That probably have to go to the admission person, like Arlene's our admission person in the small house, so she can walk you through, if you decide to go to small house, they can walk you through the payment. But I just tell you the general, like first 21 days, they usually cover 100%. And after that, it depends on your insurance. Yes.
So if an orthosurgeon does your knee and discharges you the next day because you did such a great job, then you don't have those 3 nights if you were going to go to the small house.
So if you still need a service, so that's go down to, it's more like a social work question. I can answer the best I can. So if you really still need to go to skilled service, like a small house, but you don't have a 3-day hospital stay, we call temporary transfer from your independent living to skilled nursing. Then all depends on what program you're on, because a lot of people are on a life care program, so there's no charge. You can go there, and your therapy will be charged under the Medicare B, Part B services. So therapy will be covered. Everything else will be depends on what plan you sign up with the Goodwin House.
That's really good information because someone who's done all the hard work to find the best surgeon they can, got themselves in good shape, survived the surgery extremely well, out in one day, now you're not penalized for doing it.
No, but that would be depends on what plan you have. If everybody here have a life care plan, then you can go as you please. I mean, you can stay in the small house for a few days till you're recuperating back to normal. You go back home. So that part I can't answer. But as far as the therapy part, if you don't have a skill A benefit, Medicare A benefit, you can use the Part B benefit for your therapy service.
So then when you say Part B, you also mean TRICARE, I'm sure.
TRICARE and the insurance. So when I say Part B, some people have a managed care Part B, some people have a straight Medicare Part B. So your TRICARE is the primary, then TRICARE it is. If your TRICARE is a secondary for Part B, they pay the 20%, So it depends on what your TRICARE is.
Just 2 comments, or question, then Charmin has a comment about the A and B. So if the resident is not part of the life care plan, but they have coverage for physical therapy, why aren't they able to access that in the small house and have you bill through physical therapy?
If they have a Part B benefit, yes, they can. We can build a therapy, just a therapy part, but the room and board you will pay because you don't have the life care plan. And depends, there's some plan like 90%. You can talk to Monica about that. I'm not into the detail, but I know if your life care plan, the room and board is covered, all your therapy go to your Part B benefit.
I think that the thing to understand is under Medicare A, those for 21 days, Medicare Part A covers it, okay? If you qualify for the skilled nursing stay, you had the
3 hospital stay and a 3-day.
somehow you were able to be discharged, and a lot of people do these surgeries now on an outpatient basis or a simple one-night stay, but they think you might need more support than you can get through home health, and you have to be over in the small houses. At that stage, your life care contract is covering the
Room and board. Yeah.
room and board kind of stuff in the skilled nursing, but the therapy services are covered under Medicare Part B, if you have Medicare Part B. And then many people have supplemental insurance through Medigap or, TRICARE. It depends on who's playing primary, but they're under Part B therapy services, there is the usual 20% cost sharing. So depending on
What you have.
what's covered, and that can be very confusing, I know.
What about a person, I think everybody understands the type A part, and it makes clear sense. What about the type B folks? They have a little different situation.
We're going to that. right now. The insurance eligibility. So the home health, like Jamie said, they cover under Skill A service. So it's a 100% cover. If you decide using the home health, it's 100% cover. But if you decided not using the home health, come down the outpatient, which we bill 80% to the Medicare Part B, the traditional one, and 20% to secondary insurance, whatever you have, the Medigap or, Aetna, Blue Cross Blue Shield, different, whatever, depends what you have. And there's a catch on that because depends what your secondary insurance is, the option, what you purchased when you started. They might have a co-payment. You have to pay for it. But that would be, we will try to check with our billing office upon receiving you to the outpatient, but sometimes we don't get the whole picture. That would be most likely the resident responsibility. If you know you have a high copay, you might want to check with your insurance, make sure what's exact the number. We can have a general idea, but every insurance company has so many options. You could have a United Health, insurance secondary. Some people cover 100%. Some people you have paid $20 copay. Some people you have paid $50 copay. Sometimes they pay 20%, not just $20, 20% of the service. So it all depends on what you have. So it's a little complicated. The only thing we know is if you have traditional Part B, we can bill Part B for 80%. You have the secondary general rule, we bill 20% the Part B to the secondary insurance. So we do have patient here with Kaiser. I know a lot of people want to ask that question, Kaiser. We can see Kaiser's patient, but we need to get pre-authorization from Kaiser, how many visits they give you. The hard part with Kaiser is we can't really request it on our own. Your Kaiser's doctor, anybody here using Kaiser? No? Okay. That's good. So Kaiser usually, your primary doctor from Kaiser have to pre-authorize how many visits for you to see. Now we can see you here in the building. Okay, so since nobody here, I'm not going to pay too much time on this. Both home health and outpatient, we do take commercial insurance plan. Like we just have a contract with Blue Cross Blue Shield, Aetna, and Humana. However, it all depends what your program said. Because some of the program, they will say we don't have any out-of-network service. That's the time we go to a dead end. We can't do anything here. But if they cover some of the portion, they will tell you maybe pay a higher copay for that. We'll kind of let you know. And some insurance will say you only have a certain visit a year, including PT, OT, and speech. Most commonly, one is Blue Cross Blue Shield, the secondary insurance. They give you 75 visits per year. That's including all therapy. So when you reach that 75 within the calendar year, they will stop paying. So sometimes you have to keep track on that, how many visits you use. So if you're using the therapy a lot throughout the year, you might have to count it.
So if you hit 75 and you need 4 more, can you just pay for it?
No, we'll bill them because that was usually secondary insurance. So we'll still bill Med-B for 80%. The 20% you may have to pick up for the 20% of the service. So if they only have a 75. Most of the cases I've seen like 75. Some insurance have a 60 visit. So usually we'll give you a heads up if we find out from the billing office. So you both of us need to keep track on that, how many times you're using it.
Can someone come to you without insurance and pay cash?
Yes, absolutely. If you come with a physician order, if you just want to do private pay, we're good.
How much does that cost?
So right now, current rate is for assessment, evaluation initial is $100 for initial assessment. And after that, every 15 minutes is $60. Yeah. 15. Yeah. So usually, we're talking about an hour will be $240 for an hour treatment. Okay. My math's doing right? Okay. Yeah. So Medicare Advantage, this is a different part. So if you don't have a traditional Part B, you have an Advantage, like a Medicare Advantage Part B. See, here's when we got a little situation here, because some of them need pre-authorization. They say, yes, we'll pay for it, but we have to approve it first. So that will take a little longer time for us. And then you really have to come with a really good diagnosis. When I say really good diagnosis, you can't come here like I have a hand nail, I need a PT. That's not happening. When we submit that, they wouldn't do it. It's got to be a medical reason. They're looking at medical necessity. So if I come here, I have a severe back pain, I can't move, yes, it will submit to them, ask for pre-authorization. But they usually take a little time. Depends which insurance you have. We all deal with that. Some of the insurance more difficult. They take a couple of days before they even review a case. So that time you got to be a little patient. It's not a holding up on our end. It was submitted out, but they may decide, okay, I'm going to give you 2 visits and come back and after 2 visits see if you fix them yet. So that would be go around because of your insurance, not because of the hold up on our end. The co-payment, like I said, they always have a co-payment for the outpatient unless your secondary insurance cover everything. So it depends on your plan. Any question? I know we just have a hot topic this month. We have a little glitch in the billing office. Anybody receiving an extra bill for the 20% copay, because there's a little glitch in the billing office, they'll try to fix that. So if you have a specific billing issue, please direct it to our billing office because they can explain it better than me. I can explain the general. When I look at the bill, I can verify, make sure those are the services we provided, but I can't tell you how they bill it. So if you have a question about the coding you receive from Medicare, benefit explanatory letter, like, oh, what is the ultrasound? You come to rehab, I'll explain to you what do we do. But I can't tell you the money amount because it's a billing office. When they send it to Medicare, how much pay, how much they don't. So that part I can't really explain. But you're more than welcome come to ask me if you have a question. Let me see next one. Gonna move forward. Okay, so a lot of people coming from Gil, a lot of people ask about what can expedite your scheduling and reimbursement for rehab. So basically, you know, if you, as soon as you receive the outpatient order, just bring down to rehab or let me know. Your doctor's office can fax directly to us too. Once I receive it, I'll call you. First, I will send your information to billing office, verify insurance, make sure they actually cover. If they don't cover, I'll also let you know. So you will know about it. You can decide whether you want to pay out of pocket or you don't mind about the copay. Flexibility with your scheduling. We're pretty booked down the outpatient most of the months. So when we have an opening, usually I will call you like, okay, somebody canceled today for 2 o'clock today. Do you want to take the slot? So that would be like, you know, if you really want to get in really quick, that's the most flexible way, like keep your schedule a little open for us. Bring your calendar. Upon your initial evaluation, make sure you bring your calendar in so we don't have to call you back and forth to check on the time. You have your calendar, we have our calendar, we can schedule out for the next week. Okay? So this is the same. From the schedule, I already explaining the part. You want to explain the part for home health?
So for home health, once we do receive an order or a referral, it can be from the clinic, it can be from a physician. We make sure that we go through the insurance and check that and look at everything that we have paperwork wise. We do need the difference between outpatient and home health is we do need a physician's visit, like you have either done a telehealth visit or you have gone to the doctor or you've had an NP or Dr. Croma Nelson has come to see you recently. So we can utilize that visit to help qualify for home health services. So that's in addition to the order. So once that occurs, then our home health department intake team will reach out to you directly to say, you know, we did receive an order for physical therapy and occupational therapy. We would like to get you scheduled. They ask to see what day. They also go into more insight into, you know, this is covered underneath your Medicare Part A benefit at 100%, or it's covered underneath, you know, an Advantage plan, and this is what your deductible or copay could be per visit. And then they will let you know that, you know, the clinician is going to come see you on, it could be a day that you request, let us know, and we will send a clinician that day. And then the clinician normally calls the night before with the time that they're going to be coming. So our intake calls first, though, to get all your information, give you some information about our services in general, and then the clinician will call independently to let you know the specific time on that day that they will come and work with you on the time schedule. Mm-hmm. Yes. Yes. That's a great question. If you're looking for home health, we, on our next slide here, yes, we have both departments here. So it just depends. If you are needing home health services, our main line is the 738241390. And we also have our email so that you could email either one and we could contact you back scheduling. Sorry, I don't know why it's cutting out.
I can get to the gym, but I need somebody to design a specific program so I can injure myself further.
Okay.
Are you the people?
So I think the main thing is if you would like services in your apartment and you're having more difficulty getting down consistently to the therapy gym, then home health would be a great service for you. If you're very mobile, you go out through the building, you drive, you have multiple appointments throughout activities, then rehab is a better yes, because you can schedule your direct time with them. But if you're having a harder time getting about, home health is going to come see you and address those issues in your apartment. You may belong to either one of us. So
Well, we can talk about it. If you have any question, you can ask me.
yeah.
Station and building, so.
And a lot of times, the progression of therapy services is sometimes to maximize your therapy that you can get is by starting in, let's say you're not as mobile, it's harder to get around. By the time you get to the therapy gym, you're short of breath, or you can't do your actual session by the time you get there, then home health makes sense. You get some therapy through home health. It could maybe be a month, and then we assist and we talk with Connie. Connie and I are great friends. We talk pretty much all the time, and we send her the information once you discharge from home health to continue on with therapy service in the outpatient. Once you've gotten more strength, once maybe you have less short of breath and you're able to do that session down there, then we transition.
When you do that handoff, is there another physician's order required?
Yes, but normally our department takes care of writing the order and sending it to her. Yep.
I heard her also say something about who designed her program for her gym. And what I would say is if you go to PT, they will in fact then design a program for you to do once you leave their services. Go talk to Connie.
Yeah. Both of us do personalized exercise programs and setups. So it just depends. I think the main things are the decider between the departments are the mobility factor of if you can get down to the rehab gym and still complete your full session down there, and the acuity of what your diagnosis is. If we've had patients that have come on home health that had a knee, and we do see them 3 days a week until they're able to get down to Connie for outpatient therapy. So it really just depends on, can you get out of your apartment? Are you driving? That's automatic, great referral for outpatient department. If you're having more trouble in your apartment, plus maybe you need skilled nursing, then home health would be the better option at that time. Okay. This is just a quick comparison slide also of home care, home health, and outpatient services. How home care, so an aid to assist with mobility, 1 to 24 hours a day, that's private pay. It is non-skilled and you don't need an order for that. That is the home care department. Home health, we have the skilled nursing, PT, OT, and aid once to twice a week, and it's under the Part A benefit at 100% coverage or commercial insurance. And it's the skilled care where you do need an order for it and you do need a physician visit recently or hospitalization. And it's performed in your apartment. The outpatient piece is the skilled PT, OT, and speech therapy paid under the Part B benefit at 80% for Medicare with 20% by your secondary or paid out of pocket or commercial insurance, and you need only a physician order, and that's performed in the therapy gym.